Again, the presenters will all be available in S4 Muybridge, the spatial chat, if you have any further questions that maybe we didn't get to during this time. All right, take it away, Adam.
All right, can you see and hear me all right?
Yes, we can.
Instrumented sway assessments have proven useful to identify early onset of degraded posture control and fall risk in a number of clinical populations. While persons with lower extremity amputation have similar issues, these assessments are not quite as common in this population. These assessments are usually done by standing on a force plate and extracting temporal spatial features from the center of pressure trajectory, comparing those scores to a reference group or perhaps across time to assess performance. However, there's some pretty clear barriers to widespread clinical use, including the cumbersome equipment required and really the ever-increasing array of sway parameters that has arisen over the years that sort of confounds what we should really be focusing on. So given that, we set our aim to assess postural sway of persons with unilateral lower extremity amputation using a single wearable sensor. And after that, to extract principal features of sway towards recommending a more concise and non-redundant parameter set to facilitate clinical adoption. 49 participants completed this study. They were a mix of transtibial and transfemoral levels of amputation. The protocol is a quick, quiet standing trial of 30 seconds on firm ground with eyes open and then closed. They wore a triaxial accelerometer over their sacrum, approximating center of mass sway, which has prior been validated versus force plate derived measures. From the gravity-corrected planar accelerations, 14 sway parameters were extracted, comprised of the 8 variables in this table in terms of medial lateral and anterior posterior components in some of them. Then briefly, we performed a dimensionality reduction and feature selection approach based on some prior similar work that performed a PCA analysis on the eyes open and eyes closed data separately towards describing what underlying features related back to some of the original variables. So jumping right into results, the result of the PCA analysis is initially 14 new variables that are combinations of the original variables. We observed that for both the open and closed conditions, only between 5 and 6 PCs were needed to capture 90% of the cumulative variance. So I'll just be discussing those for the remainder of the talk. So while these reduced 6 PCs are great, they're also pretty abstract and not palatable for clinical applications unless they have some sort of physical meaning. So we can explore that through inspection of what are called loadings that are in effect the correlations back with the original variables. So for example, PC number 1, which captured 40% of the variance, appeared to describe and be measuring the overall planar size of the trajectory, along with some underlying postural corrections based on the most strongly loaded variables shown at right or left, which range -1 to 1. PC number 2, in contrast, around 20% of the variance, looked to be capturing an increased visual dependency for sagittal balance that has been already reported in this patient population with limb loss due to loss of that somatization in the foot. PC number 3 appeared to be detecting lateral asymmetries that could arise from the unilateral amputation, in that it was most loaded by the ellipse rotation and 2 spectral features in the medial lateral direction only. PCs 4 to 6 weren't loaded by any single primary variable, or a combination of spectral features and this parameter called jerk. But back to our original aim, we also hope to, in addition to developing these PCs, recommend a concise variable set of the original variables that might be used for clinical applications, and I've highlighted 5 of those that we'd recommend for that purpose from each independent PC. So to conclude, we saw that efficient sway assessment was feasible on persons with amputation and also produced ranges comparable with prior work on uninjured persons and those with Parkinson's disease. The concise and independent set that we recommend here of the original variables also compares well with a similar study using PCA analysis on persons without amputation, with the addition of jerk that we recommend. For next steps, since this is still at the feature engineering stage, we of course hope to use these data to explore machine learning applications, which would classify self-reported pain, mobility, and prosthetic satisfaction in this population that we're also recording in the protocol. And that would be towards informing more efficient and earlier interventions for balance, fall risk, and low back pain across this population. Thank you.